As a valued NEI podcast listener, get $100 off NEI Fall Congress registration with code POD26. That's POD26. Go to nei.global/fall, FALL, to sign up today.
Welcome to the NEI Podcast. On this show, psychiatrist, psychopharmacologist, and chief medical officer of NEI, Dr. Andrew Cutler, sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI Podcast. I'm Dr. Andy Cutler, chief medical officer of NEI. And with me today is the founder of NEI, Dr. Stephen Stahl. And, of course, one of our esteemed faculty members, Dr. Jeffrey Strawn, and they have recently published a book called Stahl's Deprescriber's Guide, part of the Stahl's series of books. And so that's what we're going to be talking about today. So first of all, guys, how are you doing? Dr. Stahl, how are you?
Great. Good to see you, Andy and Jeffrey. And yes, it should be called Stahl's and Strawn's Deprescriber's Guide, because actually Strawn is the first author, so it should be Strawn and Stahl's. But anyway, we'll let him pontificate as time goes on.
Really excited to be here and always excited to talk about deprescribing as well as prescribing.
Absolutely. Well, that's very generous, guys. Well, let's get started. Deprescribing, that's a funny term. We're used to talking about prescribing things. So why is deprescribing so important?
So one of the things that's really interesting, Andy, I'm very curious what Dr. Stahl thinks here, is that we've focused on deprescribing as really the opposite of prescribing, when in reality, it's part and parcel of prescribing. And one of the things that my good friend Dr. Stahl mentioned as we were talking about the introduction for this textbook is that anyone that prescribes is a deprescriber. Any prescriber is a deprescriber. We stop medicines when they're not working. We stop medications when a patient experiences side effects, when we need to cross-titrate from one medication to another medication. That is really, in essence, deprescribing, as much as deprescribing is stopping a medication when it's no longer used, or needed, rather.
Mm-hmm. Well, Steve, why is it that people end up on so many different medications, and it seems like people add but don't subtract?
Well, it's amazing. Those of you who are listening who are, in the psychopharmacology practice will have seen this a lot. Patients will come in and you inherit them often on meds somebody else gave them, and they may have had a partial response, and you're afraid to stop anything because you don't know why they're better, a little bit at least, and so you just add something. You especially see that, I think, in the residence clinics when a resident only takes care of a patient for 6 months and then they're afraid to stop things. But Jeff and I have talked about this, and Andy, I think we've talked about it as well. If you're actually a psychopharmacologist, you actually end up stopping more medicines than you start if you're good. And you simplify the situation. And, sometimes you need to reestablish a new baseline off a couple of the medicines before you give a new one. But it gets too complicated, and that's why they end up with sometimes 12, 15 medications.
Yeah. I think we've all had the experience, too, of sort of finally getting this magical combination that seems to work, and then it kind of gets us to think, well, now I've got to chase that magic combination of things. What do you think, Jeff? I mean, sometimes people chase symptoms and start adding things for symptoms rather than the underlying condition.
I think absolutely. And I think another nice part to maybe bring into this discussion is the psychology of deprescribing, both for us as prescribers, for our patients, for their families, et cetera. There's often a lot of anxiety around what if deprescribing or lowering a dose of a medication actually causes my symptoms to recrudesce or me to get worse when I finally got to what I may believe is this very tenuous state of recovery.
Yeah. Yeah, and other things, Steve, you alluded to this. I think sometimes when your goal is to cross-taper, if you will, you get stuck in the cross. You overlap the medicines and they seem to get better, and then you kind of lose your courage to go all the way through to just try the new medicine alone. And so people stop. Does that happen too?
Of course, yeah. And a lot of times people are just seeing somewhat stable patients in follow-up, and they say, if it ain't broke, don't fix it. And I mean, if you ever worked in a veterans hospital, you'll see people that have been on even old-fashioned Librium since it was actually came on the market 40 years ago, and they're afraid to stop it. And so, no, it's kind of a discipline to look at situation with fresh eyes each time and ask yourself, does this patient need new medicine, or does the patient need fewer medicines? And we don't do that enough, I don't think. Sometimes you say, if it ain't broke, don't fix it, just go on to the next patient.
I absolutely agree. And I think that's also the case in our pediatric populations, as well as in our adult populations, as well as our geriatric or older adult populations. It really spans the lifespan.
Mm-hmm. Yeah. So, Jeff, when should a clinician stop and say, does this patient still need this medication or this dose or this combination?
Well, one of the things that often happens to me that I think is helpful to talk about is it's often the patients who are asking about stopping the medication. Now, certainly I've shifted as we've written this book in terms of thinking about trying to be more intentional in terms of whether medication is needed, but maybe to take a moment and say, how should we talk with patients when they come to us asking to stop medications? And I think that's probably a place where I would actually ask another question, which is, why now? What has changed in terms of that particular patient wanting to stop the medication? Oftentimes there is, in a good therapeutic relationship, some trepidation on the part of the patient in terms of, will they upset us if they tell us about an adverse effect or tell us about just the general burden of taking more pills or more medication or their individual beliefs around the medication. And I think it's certainly very important for us to have that discussion in terms of why now. One of the questions that I like to ask is, what things maybe do you not like about this medication?
The other thing is, it's a patient is staying better because of the medicines, or is the episode over and they don't need it anymore to sustain a remission? You ask that question, and the longer out the patient is from the initiation date, and the longer that they've been with, pretty good response, the more you have to ask whether the continuation of the medication is necessary for that.
Yeah, it's hard to take even one or two medications correctly every day. So I sometimes wonder, these people who end up on many medications, are they really taking them all, in the right way every day and this kind of thing? And so I just think it's hard to do that. What do you think, Jeff?
Absolutely.
Yeah. So sometimes what we may be seeing is someone who's, partially inadequately treated, or who really doesn't need all these different medicines because they're not taking them regularly. And it seems to me good psychopharmacology is to kind of do one or two things at a time before just adding. Jeff, you've talked a lot too. You've obviously spent a career looking at pharmacokinetic interactions. And I wonder if we sometimes get a little lazy and don't consider the pharmacokinetic interaction.
Absolutely. And I think, you bring up pharmacokinetics, but I would also bring up pharmacodynamics. And again, I keep coming back to also the psychological factors that drive this. But when we really start to think about how to safely and effectively taper these medications, we really need to think about all three. We need to think about the pharmacokinetics. And again, it's not just about half-life. We need to consider the pharmacodynamics and the individual receptor pharmacology. And then we need to, again, consider some of those psychological factors in terms of the patient's expectations, which are important, as Dr. Stahl and I have recently talked about, in terms of a lot of controversies that tend to accompany these deprescribing discussions. I think, to break this down maybe specifically into these individual elements, as we think about the pharmacokinetic factors, we not only need to consider how long the medication has actually been there in the system, and in terms of individual factors like half-life and clearance, certainly patients who clear the medication more quickly are more likely to experience withdrawal symptoms after even a missed dose, but also in the context of a taper. And that has implications in terms of how we taper these medications. But the other piece is really neuroadaptation. I know, Dr. Cutler, you've also talked about this a lot, including on the NEI stage. I remember one of your quotes vividly, which is that the brain doesn't like it when we do things quickly. And so I think, whenever we're talking about these medications and how to discontinue them, we have various adaptive changes that have happened when a medication has been on board for a longer period of time. In terms of receptor downregulation, we also have differences in terms of sensitivity of individual receptors. And if we quickly change the milieu in which that receptor is living by reducing the dose of a medication, that really sets us up for experiencing more withdrawal symptoms. We're experiencing more severe withdrawal symptoms. The second part of that is that if we think about the individual medications and their respective targets, as we change the dose of the medication, we will necessarily expect different responses. For example, if we think about the serotonergic system, probably one of our more complicated monoaminergic systems in the brain, although maybe that's something that we can debate. When we think about the individual decreases in the dose or the exposure, in other words, blood level over time of a medication, we know that there are various pharmacodynamic factors which will influence both the character or type of withdrawal symptoms, but also the onset pattern of those symptoms. Dr. Stahl, I'm curious your thoughts here.
Well, I think that we don't know when somebody is responding, whether that needs to go forever. Long-term trials don't exist. Registration trials tend to be, a few weeks to a few months, sometimes a year. But, being able to show that sustained remission is due to the presence of the drug is not well established. And so the question is, have the receptors done whatever they need to do to sustain their good parts? I mean, probably receptor adaptations occur for the good parts of why the medicines do work. And then, of course, there's off-target things, which actually you don't want, but are part and parcel of the drug's action. And we don't know whether readaptation also means you get rid of the drug and its side effects, or you get rid of its therapeutic effects. So we're fishing in kind of unknown waters, but the answer isn't to go to sleep at the switch and keep on just adding drugs and never considering how to stop them. So really, we think that psychopharmacologists are more skilled at adding drugs than subtracting them. And we're trying to take a leadership position in this and saying it's time for us to balance that. And to also, as Jeff said, realize that stopping a drug is part of giving it in the first place. And things like psychosis that's well established, these may be lifelong illnesses for which you don't ever want to stop a drug. But there may be other things which occurred with psychopharmacological structures that precipitated them, that when life is sailing smooth ahead and you've been well for a long time, you don't need the medicines anymore. And so that's where our judgment needs to come in, and we need to kind of make it up as we go, because they're not necessarily guidelines based upon well-studied chronic treatment and discontinuations. But we just need to encourage people to be thinking about this in long-term practice.
I think you said something really important that I wanted to expand on, because we know that in our current environment, there are a lot of folks who are anti-antidepressant or anti-antipsychotic or anti-medication in general. And one of the things that's often pointed to as evidence that maybe medications don't work long-term is the fact that when we look at the very, very, very few double-blind placebo-controlled trials that we have that extend over long periods of time, you tend to see an attenuation of that drug-placebo difference. Well, I think one of the problems there is that what we're doing is we're actually selecting for those patients who are doing well on placebo. And so again, we're seeing an attenuation of that drug-placebo difference over time. That's not evidence that these medicines don't work long-term. What I would point people to in terms of the evidence that these medications do work long-term is probably some of our discontinuation studies. And I know that was something that we both felt very strongly about including in the book. When we look at these studies in depression, in schizophrenia, in bipolar disorder, and in anxiety disorders that actually take people who are stable on a medication and randomize them either to continue the medication or to switch to placebo, what we see is relapse happens, and it happens significantly more frequently in patients who are switched to the placebo than those who continue the medication.
Yeah, of course, you're talking about the randomized withdrawal design, but in that case, usually those are monotherapy studies. And when you talk about another problem here is, Steve, you talked about the lack of evidence base. We don't have a lot of studies of combinations of medications. And if we do, it's 2 at most. We certainly don't have studies of 3 or 4 medicines, which people end up on. So unfortunately, we're practicing in an evidence-free zone, if you will, and people are left to their experience and impressions and beliefs. It's psychology, Jeff, you talked about. Are there situations when we should be especially cautious about tapering or discontinuing medication? I think you've alluded to this a little bit.
So I think, when we look at some specific disorders that have been mentioned already, in terms of many of those that are lifetime disorders or that are prone to periods of relapse and recurrence of symptoms, those are certainly situations in which we need to not just simply stop the medication and wish the patient well, but we need to continue following the patient over time. These are some of the situations also in which I will taper the medication over a longer period, maybe than what one would expect just based on the pharmacology or based on the pharmacokinetics in particular. And again, that's not for pharmacologic reasons. That's because if I'm able to follow things over a longer period of time, I have more data in terms of understanding whether that slight increase in depressive symptoms was related to an external stressor or whether it was truly the slow reemergence of depressive symptoms or of an anxiety disorder. I think one of the other situations in which we sometimes really get into problems is those situations where we essentially try to titrate the medication in reverse. In other words, stopping it in a similar way to that which we started it. So what do I mean? What I'm thinking about here is, for example, starting quetiapine, a medication that we know has a fairly complex receptor pharmacology. And in those situations, as we're starting the medication, we titrate up in a very linear fashion. However, when we stop the medication, we know that there are several predictable stopping points, if you will. So one of the things that we know with quetiapine, for example, is that at the higher doses, we'll get greater D2 occupancy. As we get to somewhere around 200 milligrams or so, we will have generally saturated 5-HT2A. And then as we get somewhere in the 50 to 75 milligram range, we will have saturated those H1 receptors. And so if I think about the withdrawal symptoms that I might experience as I'm decreasing the dose of the medication, it really helps to think about that receptor pharmacology. So one of the things with quetiapine in particular is that as I get to that 75 milligram dose, which is the dose at which I've saturated many of those H1 receptors, as I lose that quetiapine below that 75 milligrams, I will start to see rebound antihistaminergic effects. So I will see more difficulties with sleep. I may see some transient increase in anxiety, things that I might not have seen, say, for example, at the dose reduction from 400 milligrams to 300 milligrams.
Mm-hmm. Yeah, well said. I'm thinking, too, about patient characteristics that we talked about. Some patients are more brittle. They've had, so knowing the history is critical here because they've had a lot of relapses. Well, that's somebody I'm probably going to be a little more careful tapering down or pulling off medications. Especially if you've had to work a little bit to find the right combination, then somebody, as Steve said, who maybe you don't have to continue all the medicines.
Absolutely. And I love that you brought this up because it gives me a chance to maybe mention one of my favorite studies in all of psychopharmacology. It's a study looking at patients who are stopping benzodiazepines. And it's not so interesting in terms of what they found with regard to relapse and other things along those lines, but more in terms of how they dissected the psychology of whether or not a patient will experience withdrawal symptoms, what they found was that one of the most important factors was a patient's belief about the medication. So those patients that attributed their improvement to themselves versus those that attributed their improvement to the medication had a markedly different pattern of recurrence of symptoms, including withdrawal symptoms upon stopping this medication.
And how do you tell the difference between withdrawal and recurrence? That's quite an art in itself. And there's a part of one of the biggest controversies of deprescribing in when a new symptom emerges. And like you say, in some ways, people kind of talk themselves into some of the symptoms because, oh my God, because they think it's going to happen. And then that's part of the art of trying to figure out whether one can stop things and reassure people to go slower, or you can go back up a little bit, and then be in control of it. So patients being in control of their titration down sometimes is one of the tricks to make sure that they don't have self-fulfilling prophecies where they end up having withdrawal symptoms as a nocebo effect.
Can I ask a question as well? Because I'd love your thoughts on how you handle that clinically with a patient in terms of what that discussion looks like for you when you have a patient that's primed for the nocebo effect.
Well, I actually ask them what they think is going to happen. And depending on my rapport with them and whether they have a sense of humor, I might actually try to joke with them a little bit and say, well, I wonder, we start this, we know we're going to get this. You remember the last time you did X or Y. And, most of these people get to that nocebo effect because they earned it, which means they've had trouble in the past and they foresee the same problem again. And other things have to do with being, like you say, psychologically dependent on the medication, in which case it may not even be a good idea to stop it at all. But going slow and having them in control of it and saying, watch out for, but it's like the consent forms that Andy and I have done, and you, Jeff, when you go to clinical trials. And one of the worst ways to actually get a placebo side effect is to read a consent form where it tells you all the things. And so what these same patients do, the ones that are most worried, where are they going to go? To the internet. And they're going to get, a lot of reinforcement. Oh, this is a horrible thing to do. These are the things that are going to happen to you. And maybe they're irreversible. Maybe they'll damage your brain. And so, you warn them to say, this information's out there. And let's look at the risks versus the benefits of even trying to get off this medication. And you know what? If you don't want to do it, we won't have to do it. If you want to stop, we'll go back to this. And you don't have to stop this stuff, and make you feel in control.
Yeah, I've had patients come back to me with the informed consent form, to your point, Steve, having circled a couple of these things and said, I have that, or I'm afraid of this. So yeah, putting it into context, and people don't like surprises, so you have to warn them about what to expect. Are you looking to stay current in psychopharmacology without falling behind? Well, NEI membership gives you on-demand access to expert-led education, practical clinical tools, and resources you can use right away. From master psychopharmacology content to patient education materials and CME opportunities, it's all in one place. Join thousands of clinicians who rely on NEI to sharpen their skills and improve patient care. Learn more at NEIglobal.com. Jeff, I want to get back to the point Steve raised about how can you tell the difference between relapse, rebound symptoms, withdrawal effects? How do you sort of parse through all that?
This is such an important question. And really what we probably need to do is talk about this in terms of the specific medication classes, because it is very different for a mixed dopamine serotonin receptor antagonist versus an SSRI versus a tricyclic, et cetera. So I'm going to maybe start with the SSRIs because I think that's one of the places where we actually have a lot of evidence Also, as Steve has mentioned, there's a lot out there on the internet around SSRI withdrawal and this issue of protracted SSRI withdrawal or tardive withdrawal, et cetera. But in terms of thinking about how to distinguish first withdrawal symptoms from relapse, time is really a very helpful diagnostic instrument here. And I think we can get a lot of data and actually encourage our patients to work with us in terms of collecting that data. The classic example is that patient who has, for example, missed 2 or 3 doses of the medication and experiences some withdrawal symptoms. That's probably a patient in whom I will start to maybe go a little bit more slowly. The other thing is when we actually look at the symptoms for SSRI withdrawal, if that's the term that we can agree upon, there's a really nice meta-analysis that I believe was published in JAMA Psychiatry maybe last summer or so. And it very nicely looks at the double-blind discontinuation phases in many of these large randomized controlled trials that are used for registration purposes. And they find that there are a couple of symptoms that are actually specific to withdrawal phenomenon. The first one tends to be more vestibular type symptoms, patients complaining of some degree of vertigo or dizziness, as well as some autonomic symptoms. It's important, especially when you treat patients on the younger end of the age spectrum like I do, to also recognize many physical symptoms can also go along with the disorder that we're treating, whether that's a depressive disorder or whether that's an anxiety disorder, et cetera. And so I think also taking the time to look at how things started, if we can, when the depressive disorder began, when the anxiety symptoms first emerged, oftentimes that gives us a clue as to what reemergence of this disorder might look like again in the future.
Yeah, that's a really good point, because you're right that sometimes somatic symptoms are associated with the illness. And then I'd like to add to your list there of SSRI withdrawal, gastrointestinal symptoms can certainly be seen, but that can also be seen, as you said, with anxiety. So yeah, understanding their particular symptom profile of the illness, that's a really good point. It's really helpful.
I mean, to amplify the time, withdrawal symptoms often occur immediately, particularly if you're going too fast. And relapse symptoms, particularly in depression, don't necessarily, you miss one dose, you get depressed again? I don't think so. So the ones that are more delayed can often be, if you have nothing and then you start getting it weeks later, that could be relapse more likely. As soon as you lose some receptor on some drug on the receptor, you're a candidate for some withdrawal.
Yeah, and the same thing holds true for schizophrenia, Steve. If you look at the randomized withdrawal studies for schizophrenia, people don't always start relapsing right away. It kind of comes on a little bit more over weeks. So that's an excellent point about the time.
Andy, I think that's also a really important point, because this is where the pharmacokinetics really seems to play a very important role. For example, when we look at the double-blind discontinuation studies, particularly in schizophrenia, and we look at some of the medications that either have active metabolites and or have very long half-lives or very slow clearance, what we find is that relapse occurs much further out for those agents than it does with some of the medications that have much more rapid clearance and lack active metabolites.
Yeah, cariprazine's a good example. The cariprazine randomized withdrawal trial showed exactly that. It was several weeks before you started seeing the relapse.
Absolutely.
One of the things we may want to do is tell the audience that if you kind of have an idea of what the median symptoms are of well-established withdrawal, let's say from SSRIs, and when they occur and what they are, and how fast they occur depending on how fast you titrate, that will tell you how you get people to either switch or discontinue an SSRI, generally speaking, maybe 80 or 90% of the people. And it's usually, obviously, there is a withdrawal phenomenon, but in the randomized withdrawal studies or just, that when people were going into extensions, most of those people that had withdrawal got over it. It was kind of an overdose that lasted a couple of weeks. And they had things that that Jeff was saying, the more dizziness and electric zaps is a common one, and things like that had nothing to do with their depressive illness in the first place. But then I think, Jeff, is this time, should we tackle the 5 or 10% patients that you may see that discontinue medicines that will come in and be part of this group that believes that they have been done a misjustice by being on the medicines in the first place, and that they were never sick in the first place, and now that they're addicted to the medicines, and it'll take 2% withdrawal per month over 4 years in order to get off of it. I'm kind of mocking it a little bit, but you can tell how I feel about it. But the reality is, you who are listening in here may actually have some people that have that, and maybe we should give them some guidelines of how you would handle that.
So I think there's been a lot of discussion around these patients with either very persistent, long-term, quote unquote, withdrawal symptoms versus patients who maybe go for a period of time after stopping the medication and then experience some other symptoms. I think this is, again, where the time course can be very helpful when we think about when those symptoms actually emerged, and also how those symptoms really overlap with the symptoms of the primary disorder, whether that's a depressive disorder or an anxiety disorder, but also recognizing that there may be other symptoms like tardive dyskinesia, which can have a fairly long chronic course post-discontinuation of an antipsychotic medication. So in terms of thinking about those individual patients, I think one of the most important takeaways that I can give to folks listening is to be patient and be open in terms of those symptoms that the patient may be experiencing, recognizing that our literature is somewhat limited. Most of our even well-designed double-blind discontinuation trials do not follow patients over very, very long periods of time. I think the other thing that is important is that for many patients who have been on, for example, an antidepressant for some period of time, particularly if they began the antidepressant earlier in their life or early in the course of illness, as their generalized anxiety disorder, for example, was treated, that may have been a patient who also was likely to develop major depressive disorder down the road. And it's very unclear whether treatment with an antidepressant would abort the development of a subsequent MDD episode in a patient that was predisposed to develop that. And so I think also if that patient was treated for generalized anxiety disorder, for example, making sure that these newer symptoms aren't related to a new onset depressive disorder or another type of anxiety disorder. I think also another factor that I like to consider is really the psychological context. You both know that I do a lot of work with patients with anxiety disorders and really love working with patients with anxiety disorders. But in that population, avoidance tends to be the primary mechanism for many people in dealing with their anxiety. And so one of the things that I often do worry about in terms of these individuals who have continued to experience these various, physical symptoms is the way in which this perpetuates ongoing avoidance and ongoing anxiety symptoms as well. So it's really a challenging group of individuals to work with. I want to be careful of not blaming the patient, but in terms of the lack of data that we have, the heterogeneity of these particular symptoms, and also the lack of data in terms of how to manage these longer term potential withdrawal symptoms.
Yeah. Well, you brought up something else really important, which is kind of the rule of the kingdom is comorbidity. So our patients can have more than one psychiatric condition, and it's possible that one medicine isn't really enough to cover all of the conditions. So sometimes polypharmacy can be rational, if you will. But before we get into specific medicines, I have a question for you guys. When a patient is taking multiple psychiatric medications, how do you decide which one you're going to address first?
Well, taking two of something that's the same, that's easy, you get rid of those. But exercise, two antipsychotics, two benzos, that kind of thing. Then I get the question is, are they having a current side effect burden from any of them that you can already figure out, wonder if the problem, you would take that. Otherwise, it would be, where are you headed from here? Are you trying to get them on a drug-free regimen? Are you trying to reduce dose? Are you going to switch them? So I think that kind of is individualized. What do you think, Jeff?
Yeah, I absolutely agree. I think, barring issues related to tolerability or significant side effects, and, what you've mentioned in terms of, I don't want to say therapeutic duplication, but extensive therapeutic overlap, I will also look to the temporal course of the treatment. So in terms of what was actually added last, perhaps it was an augmenting agent added to an antidepressant in a patient with severe refractory major depressive disorder. That tends to often be the first thing that I might target in terms of those discontinuation discussions. Notice I didn't say discontinuation. I said discontinuation discussions.
Yeah, it's interesting, though, because if you're talking about that scenario, there's actually a lot of evidence that some of the atypical antipsychotics are antidepressants in their own right. I mean, we know that many of them are approved as monotherapy for bipolar disorder, but there's lots of evidence that some of them work as monotherapy for MDD. And so perhaps you might even consider tapering off the, let's say, SSRI or SNRI. I've had patients say to me, do I have to keep taking this medicine that wasn't working all that great and it's causing sexual dysfunction and weight gain? And the answer may be no. So that's an area where there's not a good evidence base on how to do that. But, another pet peeve of mine, guys, besides the overlapping therapeutics, if you will, is anticholinergic medications. I think we would all agree that we're probably using too much anticholinergic medicines, and I'm really concerned about any cholinergic burden. So I guess, would you guys agree with that?
I would absolutely agree with that. And whenever anybody talks about discontinuing anticholinergics, I'm sure that all of us are thinking about one other specific NEI faculty member, Les Citrome, who is often talking about this. But we certainly have really several decades of evidence that suggests that anticholinergic burden is directly related to neurocognitive impairment. And some of these studies are really beautifully designed in terms of neuropsychological testing before, during, and after treatment with an anticholinergic.
Yeah, even medicines that aren't specifically an anticholinergic, like, say, a benztropine or diphenhydramine. We mentioned some of the atypical antipsychotics, the penes, for instance, have a lot of inherent anticholinergic activity. And then there's other medicines people may be taking from other clinicians or for general medical conditions that can have some anticholinergic effects as well. So I think that's another important principle. It's not only psychiatric medicines. We have to look at all the medicines somebody's taking, I think, to decide these things. All right. Now, if we could, how about if we talk about some specific classes of medications? We've already started with antidepressants and SSRIs, but I think one important consideration is that thinking, Jeff, we talked about thinking about pharmacokinetics and pharmacodynamics. So pharmacokinetics, we know that the shorter acting drugs, paroxetine, for instance, you have to be even more careful with your withdrawal. Fluoxetine with a very long half-life, maybe you don't have to go as carefully or slowly because it sort of auto-tapers. And then the SNRIs, that may be more of a pharmacodynamic issue. They can cause significant withdrawal symptoms. So I guess you wouldn't taper them all the same way, right?
Absolutely. And I think we should probably spend maybe a couple minutes, if we have it, talking about paroxetine. And this is one that Steve and I talked a bit about as we were writing the book, because I really love one of the things that we discussed, which was the idea that you have that mechanism-based inhibition with paroxetine. So as you titrate paroxetine, your clearance of the drug actually decreases. So the half-life increases at higher doses. The drug lasts longer when you get to a higher dose of paroxetine, because again, the paroxetine metabolite is actually covalently binding to that 2D6 protein. It cannot be released. It's covalently bound. It's permanently inactivated. Well, what happens as you're actually decreasing the dose of paroxetine is you actually speed up the clearance. So you actually accelerate the onset of withdrawal symptoms and magnify or amplify those withdrawal symptoms. So it's really a special situation when we think about the pharmacokinetics there.
Yeah, so it's more than just half-life. That's really interesting. Let's shift over to antipsychotics real quickly. And, I always hate talking about these things as one monolithic class, because certainly the antipsychotics, as Steve had a catchy song years ago, the peens, the dones, 2 pips and a rip. And of course, now we have a roan with lumateperone, but they differ considerably with their pharmacokinetic and especially receptor binding or pharmacodynamic profile. So Steve, how should I think about those medications?
Well, I think the first question is, what's the setting? If somebody is actively psychotic, you do it quickly, and you're going to actually, of necessity, go to another one. If it's someone that is young and had a first episode and maybe has been treated for 6 months or a year and you want to taper it, then you would, I think, get them ready, including the people around them. Be more vigilant to the reemergence of psychosis, and be ready to reverse course. So I think it's very setting dependent. I mean, some of the medicines are easier than others. The ones, as you say, with anticholinergic side activity, such as, even clozapine. Clozapine is notorious for reasons. You never say never, but you never really try to taper clozapine any faster than about 4 weeks. There's something about reemergence of psychosis that's rather unique to that specific agent when precipitously discontinued. The rest of them, basically, you have like you say, a pene, olanzapine, quetiapine, those agents are not easily tapered faster than 2 weeks. You can't.
Yeah. Oh, yeah, at least.
The issue would be go longer if you can. And so it's possible usually the dones are a little bit easier to taper in the sense in practice. And like you say, cariprazine and drugs like that taper themselves because they have such long half-lives. So it's pretty, there's a customized way of thinking of each of those drugs, but it's also setting dependent. I'm talking mostly about people who maybe are taking it for non-psychotic reasons. I mean, for example, like with Bay, you're taking it augmentation of an antidepressant. That's a different situation than if you're taking it for psychosis.
Right. Well, I guess where it comes up is I'm a little concerned about stopping antipsychotics in people who've demonstrated, schizophrenia or an ongoing psychotic disorder. But it comes up when you get asked about switching all the time, because you're going to be tapering off of the previous drug and then starting a new one. And I guess it really does depend on these considerations we're talking about. Jeff, do you think, is cross-taper always the best idea here? How do you think about that?
Yeah. Actually, before you ask that question, Andy, can I go back to one other thing real quick?
Yes, please.
So this is really an interesting discussion that we're having in terms of how to taper the antipsychotics. And we've certainly spent a lot of time talking about the speed with which we taper these medications. But there was a really interesting study that was also just published last year in 2025. And one of the things that was observed in that study is that the strength to which the medication actually binds to D2 was associated with the time of relapse and the actual amount of relapse. So in the study, the antipsychotics that were associated with the highest rates of relapse were the highest binding D2 antagonist. And what's really interesting here is that this elevated risk that we see is probably something that may relate to this whole idea of a dopamine supersensitivity phenomenon. So I think that's really important in terms of we often get very fixated on the speed of the taper as opposed to thinking about speed as well as the individual medication.
Yeah, that's really well said. Yeah, you're 100% right that if you are very potently blocking D2, the brain doesn't like that and it upregulates, if you will. And now if you're withdrawing the drug, you've got this like super sensitive upregulated dopamine system that's more
It's like peeling off Velcro, right? Whether you do it slowly or whether you do it quickly.
Yes, well said.
So the faster you pull it off, the more disruptive it actually is.
Yeah. Well, let's approach the elephant in the living room, which you've already talked a little bit about, Jeff. Let's talk about benzodiazepines and sedative hypnotics. especially in patients who've been on them for a long time.
So this is really a great one to talk about. We probably should have started actually talking about the benzodiazepines, but I think this is one of the situations in which the pharmacokinetics just comes through beautifully. So we know that the emergence of withdrawal symptoms is certainly different for a medication that has a longer half-life. And in the case of the benzodiazepines, many of those medications also have active metabolites versus a benzodiazepine that tends to be more lipophilic as well as more rapidly clear. When I'm probably thinking about the benzodiazepine that everyone listening to this podcast right now is also thinking about, and that is alprazolam. When I think about alprazolam, I discontinue it very differently than I do for other benzodiazepines. In many cases, outside of obviously an emergency situation where I need to stop it more quickly, I will actually convert it to longer acting benzodiazepine with less lipophilicity. And I'll use the benzodiazepine equivalence tables, but I won't just convert it to 100% of the new benzodiazepine. In many cases, when it's alprazolam, I'll actually convert it to 120 or 125% equivalent when I'm thinking about that new benzodiazepine. And in patients that have been on the benzodiazepines for a long period of time, I tend to taper more slowly. There are a couple other things that we do know about tapering benzodiazepines. In other words, there are some specific risk factors for more difficult withdrawal. Number one, being on the medication for a longer period of time. Number two, it being on a higher dose of the medication. Number three, higher pre-treatment anxiety. And number four is personality pathology. So with regard to those last two things, I want to make sure I do everything I humanly can to make sure that those things are optimized before I even begin my taper.
Boy, that sure makes sense. Yeah, I was actually taught to convert from alprazolam to clonazepam, I guess, longer acting.
That's actually what I do.
Rational. Yeah. Okay, so good. So that makes sense. Well, I agree with you. And Jeff, this is where my dictum comes in. The brain doesn't like you to do things fast, particularly if it's accommodated over time, over years here. So I think we do have to be very prudent. And I think also we have to address our patients' concerns because they are, benzos are effective. They work for anxiety. And when we start pulling them away, they might start to have the little beginnings of some anxiety. And so I like what you're saying, that there's other ways maybe to address the anxiety and help them through that. So shared decision-making and support is critical here. Yeah. What about sedative-hypnotics? Let's say the Z drugs or even a trazodone or something like that.
Well, it's not clear that they even work after a couple of months. The act of taking a medicine before you go to bed is not necessarily the same as pharmacology. So the people, they certainly do work upon initiation. So the question is, to what extent is pill-taking behavior actually driving the onset of sleep? And what is pharmacology? And if you begin to discontinue the drug, you will find that out. And so, the idea would be you can taper both by dose and by time. You can take less of it, but it's often better to say, why don't you skip it a night and then see what happens and take it again for a few nights and then skip it. You end up, having more and more skips, and that's one of the ways to discontinue it. You can also transfer them to something else, like Jeff has said, other indications. It won't be the same feeling for people. Like trazodone doesn't really substitute for Ambien, but it's something that can work. You can use antihistamines and others sedating aids. But, the question is, why aren't you able to go to sleep? That's a good question in its own right. Are you bipolar? Or are you, one of the best signs that you're going to be going into mania is that you end up having insomnia first. And the same thing for are you basically kindling an anxiety disorder? And that's really what you're treating. And the better thing would be to address that with different types of medications during the daytime.
That's a really good point, Steve, is maybe you're not treating the core illness and the insomnia is a symptom of something else that hasn't been adequately treated. So that's an excellent point. Well, guys, as we unfortunately get close to the end of our time here, we're going to have to wrap up soon, but I do want to make a pitch for the book. Guys, Jeff, are there tables and kind of visuals and things that are very practical to help a clinician through here?
Of course, there are copious illustrations and numerous tables throughout the entire book, and we've really worked hard to ensure that those were included, both to give clinicians a how-to and suggested guide in terms of not just one tapering strategy, but oftentimes multiple tapering strategies that one might use. One of the other things that we've really done is to try to address one of the questions that you asked earlier, Andy, which is how do we differentiate withdrawal from relapse? And we've done that for all of the medications in terms of those things that we've talked about here on the podcast, the timing, the specific symptoms, the response to reintroducing the medication, et cetera.
All right. Well, as we wrap up, I would like to leave our audience with some take-home points. I'm going to ask Steve first and then Jeff, what are the most common deprescribing mistakes that clinicians can make?
Never doing it or doing it too fast.
I love it.
I should have jumped in there and gone first because those are the exact same things that I would say. I would probably also add one other, which is not attending to the psychological factors that may be contributing here. Oftentimes we've talked about the negative expectations, but there's also not just an expectation bias, but a really distress tolerance problem in terms of a patient who has done very, very well, or maybe has an anxiety disorder and has done very well. I'm worrying about whether they themselves would be able to manage withdrawal symptoms should they emerge.
Yeah. And I guess I would also add, too, along lines of shared decision-making, is asking patients what are these medicines doing for them or why were they added? And they may not know sometimes. And also the concept of chasing the symptoms, people just throwing medicines at symptoms rather than, like what Steve said earlier, not adequately treating the underlying condition, if you will. But yeah, I totally agree. I like to joke sometimes. I feel like sometimes in my career I've done as much good taking people off meds as I have putting them on meds. And sometimes taking a fresh look and cleaning them up can be extremely helpful.
Having said that, Andy, I want to leave you with one thought, which is I would tell my patients it's not a badge of honor to be off all medicines, and that's the goal, because that's a good thing to have in and of itself. I say when you get to the pearly gates in heaven, if that's what you think happens after you die, you don't get credit for the fewest number of pills you took on earth. You take credit for the fewest number of symptoms you had on earth. So it's still about feeling good, being in remission, and not really about taking the drugs, not gratuitous prescribing of stupid drugs. So we don't want to do that. And so it's a balance. There's a balance between the two.
Absolutely. And I'm reminded of what a friend and mentor of mine, Terry Ketter, once said. When I'm thinking about the idea of risk and benefit, we think about risk, we think about side effects, and maybe we can throw in withdrawal effects. But Terry once asked, what is the risk of inadequately treating our illnesses? And I think we all know the answer to that. And sometimes you need more than one medication. So doing it thoughtfully, I think you're right, is the key.
That's such an important point to end on, because I think oftentimes these narratives sometimes become a bit polarized, particularly around deprescribing, with individuals really worried about the harm that may occur as a result of any medication, not just thinking about psychotropic medications. But we really would do well to remember that there is considerable harm potentially in stopping a medication that has been effective if a patient goes on to relapse or to experience more profound functional impairment.
Yeah. Well, guys, I feel like we just scratched the surface of this really clinically important topic. So I'm going to have to, again, recommend to our audience, please consider this book, which goes into more detail and has a lot of visuals, as you said, illustrations and tables. And I want to thank you, the audience, for listening. Of course, for more information about our various educational offerings, including our live meetings, our virtual Saturday morning live, more of these podcasts and so on, please go to our website, neiglobal.com. So, guys, I really want to thank you. Jeff, thank you very much.
My pleasure. It's always great to be here with you.
Likewise. And Steve,
Okay.
final word.
Yeah, thank you.
All right. Take care.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.